Let's join Dr. Robert Docks for a discussion on acute CVA and TIA.
This topic is sort of a heavy topic. The other topics we'll do later this afternoon are kind of more fun, the trauma, the bites, things, but stroke is just a heavy topic. So bear with me, we'll dig through it, and we'll move on from there. So nothing else, I have nothing to disclose. Here's our learning objectives. Here's the plan for the 30 minutes. I want to do first risk factors for stroke and primary prevention. Then I'll talk about how to manage acute stroke, then secondary prevention in your patients who've had a stroke, and then last, TIA, because everything has changed. Acute stroke events are the most often the result of which of the following pathologic processes? Is stroke most commonly due to acute thrombosis, B, acute embolic event, C, acute intracerebral hemorrhage, or D, acute subarachnoid hemorrhage? Okay, so it's acute thrombotic events. We'll go through it. Here we go. This is just the framework. Ischemic strokes, 80 to 85% are ischemic strokes. Decreased blood flow to the brain, that portion of the brain dies. Hemorrhagic stroke make up 15 to 20%. When you go back and look back at ischemic strokes, thrombotic is 2/3 of them. Half the time it goes into the large vessels, half the time it goes into small vessels. Embolic, you see, makes about 1/3 of the ischemic strokes. Okay, so just so we get our lingo straight, what's a cryptogenic stroke? The last lingo thing here is, it's an ischemic stroke. It's an ischemic stroke, and you go searching for where that occlusion is. You do your carotids, you do your CTAs, you do an MRA, you look for the occlusion, and you can't find it. All right? You can't find it. You can't find the cause. But it's an ischemic stroke. It was not a hemorrhagic stroke. That's a cryptogenic stroke. So risk factors, there's the traditional versus the novel ones, there's modifiable, and then there's the non-modifiable ones. You can't do anything about your age, sex, family history, and ethnicity. Here's your traditional risk factors. You know them, you love them. It's hypertension, AFib, diabetes, physical inactivity, smoking. And you can see hypertension leads the list. Why does hypertension lead the list? Because hypertension is associated with all types of strokes, both ischemic and hemorrhagic strokes. So the $64,000 question is, if you can control the blood pressure, can you decrease the risk of stroke? Good question. Good question. Answer to that is yes. And we know that from these old studies, these traditional studies. Again, if you're of my age group, you might remember some of these studies coming out in the late 80s, early 90s. SHEP was a big one, for example, where they took patients with hypertension. Half the patients got an antihypertensive, half the patients got placebo. And then they watched them for a couple of years. And lo and behold, those who got the antihypertensives had less stroke. Now, again, the names of these would be unlikely to be on the boards, but please be aware that these studies will never be replicated again. These studies can't be replicated again. Think about it. Why? All right, you have hypertension. We're going to give you a placebo. That ain't happening, right? That ain't happening. So this is what we're going to rely on as we move forward. So diabetes is also risk factors for stroke. This is the patients who tend to get the lacuna or small vessel strokes. And then you have AFib, which often gives you the embolic strokes. As I started talking about in the last lecture, again, you have a patient who's not anticoagulated. They develop their clot in their atrium, breaks off, goes upstream. This is one of those slides, pull out, put in your study folder, because there's 3 big bullet points on this. And I like to start at the bottom. The bottom bullet goes like this. If you take all comers with AFib, that's young, old, very old, all AFibbers, all age groups, if you do not anticoagulate them, the risk of them having a stroke is 4.5% per year. 4 to 5% per year if you don't anticoagulate them. If you do anticoagulate them, you drop that down to 1.5% per year. 2/3 reduction, 66% reduction. Relative risk reduction. Second point, if you don't anticoagulate them and they have a stroke due to an embolic phenomenon, those are big and those are bad strokes. Large morbidity and mortality. Last point. The older you are, the greater the bang for your buck putting the patient on anticoagulation. The older you are, the greater the risk that that clot's going to break off and go up to your brain, more than a younger person. So who should we anticoagulate? Many of you have probably gotten very used to this CHADS-2 scoring system. So the CHADS-2 scoring system is there in front of you. You get 1 point for most things, 2 points for a prior stroke. At least when I took the boards, they did not ask me to start, adding up scores in case scenarios. I would not spend your time, 1 point for this, 2 points for that. Don't try to memorize that. That's why you have a smartphone. All right? That's why I have a smartphone. So just know the outcome. If it's 0 points, you have the option to put the patient on aspirin. 1 point, aspirin or anticoagulation. 2 points or more, anticoagulation. Now, to make things a little, not more confusing, but you should be aware, ACC, American Heart Association, 2 years ago said, CHADS-2 is nice, but we really like the CHADS-2 VAS score. What's that? Well, it's just more points. And they did say, well, listen, what's so special about age 75? We know when you're 65, you're higher risk than when you're 55. So when you're 65, you get 1 point. You're 75, you get 2 points. We know women have a higher risk than men. They get a point now. So there's more points. Don't try to memorize them. But the bottom line still is 0 aspirin is an option. 1 point aspirin or anticoagulation. 2 points anticoagulation. Okay? So again, this is just one of those take-home slides that just re-emphasizes what I showed you earlier. This is not an ordinance response, just play along. Which of the new novel oral anticoagulant drugs that are out are approved for the management of non-valvular AFib to prevent embolic strokes? And the answer is all of these are. If they happen to ask you which of these new ones can you use for DVT-PE, the answer is all of them. They've all been FDA approved for those 2 indications. Okay? All right, moving on to the other risk factors. Physical inactivity and smoking. You believe me, if you increase your physical activity and you stop smoking, you'll decrease your risk of strokes. I don't have to prove that to you, hopefully. Okay? The novel ones. There's a lot of novel ones out there. So does anybody get Medscape? I was just rolling through Medscape and I was looking at all these novel, different things that increase your risk for stroke. Like if you don't eat breakfast, you have a higher risk of stroke. I mean, these are really weird, odd things. Migraine is one, some of the rheumatologic diseases. You don't have to know these, okay? The only one I think you should be aware of, at least for your daily practice, is antidepressants. Antidepressants? Yeah, those SSRIs, the thing that like almost everybody's on. Yeah, one of those drugs. Yeah, they actually increase your risk for a hemorrhagic stroke. Hemorrhagic stroke, why? Well, because SSRIs have antiplatelet effects. So you have antiplatelet effects, so increase your risk of bleeding. It's actually shown if you take an SSRI and an NSAID, you quadruple your risk for a GI bleed. Right? So just be aware, they're generally benign, very useful drugs, but however, there's always a downside to every drug. All right, so here's the intracerebral hemorrhages we've worked into. There's a lot of risk factors: hypertension, amyloid angiopathy, and obviously drugs, including cocaine, SSRIs. The other hemorrhage in your brain you just need to know about is subarachnoid hemorrhage. This is due to Berry or saccular aneurysms at the base of the brain. This is the person who develops a sudden, severe thunderclap headache, worst headache of my life, usually at the base of the brain. They have the nuchal rigidity. They often are vomiting. My one take-home point on this, how I'd just like to make is just look at the peak age. People who get ruptured subarachnoid hemorrhages is middle age, 40, 50, 60-year-olds. Drives me crazy when I'm working an ER shift and a patient, a 14-year-old, gets sent in from the office because they're worried about a subarachnoid hemorrhage and get a CT. I mean, yes, it can happen. I'm sure you've probably heard of the case, but that's not the age group that ends up busting their aneurysms. All right? You with me on that? Okay. Let's go on to when the patient shows up with their stroke now. 82-year-old male developed sudden dysarthria and right upper quadrant weakness. Onset was 8 a.m. He arrives in the emergency department at 11 a.m. and IVs inserted, labs are sent. Which of the following imaging studies should be ordered stat? A non-contrast head CT, a contrast head CT, CTA angiogram of the head, or a non-contrast MRI? Great, perfect, you know this. You get a non-contrast head CT. Why? You're trying to answer only one question at that point in time. The one question is, bleed, no bleed. That's all you want to know. And bleed, if you have blood down at the bottom, it often shows up white. For those of you who looked at these, you see these, it's white. If it's no white, no blood, it's ischemic. Right? In fact, you'll often get the report back, looks normal, because it does look normal early on. You don't have the changes early on. All right. So we're going to get into this case a little bit more depth. Goes like this. That same 82-year-old male comes in with sudden dysarthria and right upper extremity weakness. It started at 8 o'clock. He comes in the ER at 11 a.m. His blood pressure there is 200 over 100. It's now noon by the time you get the labs back in head CT, and they're reported as normal. Now your management will include, follow along, A, you're going to start thrombolytic therapy, TPA, and also initiate nicardipine for blood pressure control, and you're going to start an aspirin. That's A. B, you're going to do both the TPA and the nicardipine, but not the aspirin. C, you're not going to do the TPA, but you are going to do the blood pressure management, and you're going to do the aspirin. Or D, you're not doing TPA, not doing nicardipine, but you're going to do the aspirin. Whew. Well, this is, now, I put this question in specifically because some of you often ask, should I do the emergency medicine urgent care part of the boards, right? So if you can answer this question correctly, go for it. All right. I don't know if David mentioned this. I know he sometimes does early on when you're asked about, the modules to do. A lot of times people often feel the urgent care is one of the more difficult ones. If you do emergency care, do it. If you do urgent care, my sense when I took that part of the boards was that it was a lot of inpatient hospital medicine stuff. So that was my take home on it. All right, so just be aware. So the answer here is D. The answer is D. Why? Let's do this. Why is it D? Let's first start with the TPA thing, the thrombolytics. I'll do this briefly. There's 12 studies that looked at thrombolytics versus placebo. Only 2 have ever shown to be useful. The other 10 said this drug doesn't work or is harmful. But 2 have been shown to be useful. And the one that got FDA approval was based on this study called NINDS. I don't think you have to know the name, but just follow with me. 600 patients, acute stroke, came in within 3 hours, normal head CT, ischemic stroke. Half got the drug, half did not get the drug. And what did they find? A, did not save lives. I say that again. TPA does not save lives. B, they looked at the patients 24 hours later. You say, you open up the clot, the brain should be better. I should be dancing and playing piano. No difference at 24 hours. It's odd. What they did find was a difference at 3 months. What did they find at 3 months? The group that got the drug, 50% had minimal or no disability versus placebo, which was 38%. The difference is 12%. Number needed to treat is 8. So 7 out of 8 patients don't get benefit. 1 out of 8 gets benefit at 3 months. That's the word. Here's the downside. This drug breaks up clots. Sometimes you want a clot. And it's been shown that about 6% of patients, if you give the drug, actually bleed into your brain. Number needed to harm is 1 in 16. So 1 in 8 benefit, 1 in 16 harm. That's life in the ER, right? Okay. So some of you might be savvy and said, but wait a minute. I now know you can give it at up to 4.5 hours. What about that? Well, that's the second study, ECAS-3. And ECAS-3 said, yes, we're going to give this drug up to 4.5 hours after the onset of symptoms in patients under the age of 80. And what they found was a whopping 7% difference. Number needed to treat was 14, and they had a little less hemorrhage in this group because it was a younger group, but only in patients under the age of 80. And in the case I gave you was an 82-year-old male. So here's your take-home slide on thrombolytics. One slide. There it is. You have to have no evidence of hemorrhage, no at all, no history of hemorrhage, no seizures. Blood pressure has to be controlled. If you're under the age of 80, you have up to 4.5 hours to give the drug. If you're over the age of 80, you have to do it all within 3 hours. All right, so that answers the thrombolytic part of the question. What about the control the blood pressure part of the question? In this situation, the American Heart American Stroke Association says, do not treat blood pressures in acute CVA, ischemic CVA, unless it's over 220 over 120. 220 over 120. Which is a real change from when I started 25 years ago when we tightly controlled the blood pressure. Why is that? And the reason is in the thinking goes like this. You have this area of ischemia in your brain. You have this watershed threatened area around that known as the penumbra. And if you start lowering the blood pressure too aggressively, you're not going to feed that penumbra, and that portion that's sort of tenuous then dies also. So you'll find a lot of patients come on in with their acute ischemic stroke, very hypertensive, and it's a little bit of a physiologic phenomenon, a normal physiologic phenomenon. Think about it for a moment. If a portion of your brain's not getting any blood, your brain's saying, hey, buddy, kick it up a notch, all right? Send some of the goods up here, all right? So that is a normal physiologic response in many situations. So don't go treating it unless it's over 220 over 120. Little different if it's hemorrhagic stroke. Makes it tough, you understand. But if you got a hemorrhagic stroke, you want to get the blood pressure less than 140. Other things about acute ischemic strokes, how about anti-seizure medicines? Prophylactically, just say no. Heparin, just say no. Warfarin, just say no. What about clopidogrel? Just say no. Well, maybe in TIA or just minor stroke goes like this. This came out from American Stroke Association just 2 years ago based on this study in China known as a CHANCE study where they gave patients with minor strokes, that's an NIHSS score of 3 or less. They got aspirin and clopidogrel versus just aspirin alone, and they found a benefit at 90 days. So the recommendation, and it's only a class 2B, B level, is on this combination, you might be considered to add clopidogrel. I hate recommendations like that. Why do I hate recommendations like that? I go to a guideline because I'm considering something. Then what do they say? Consider it some more. What's that? So you get to consider it some more in that situation. All right. What about the yeses? Just say yes to aspirin, just say yes to antipyretics, say yes to treating hyperglycemia, and yes, do swallowing studies before feeding. Stroke units, I'll just make one quick note about stroke units. If they give you the option about stroke units, just say yes. They've been shown to decrease morbidity and mortality. Why do they do that? It's because they do all the low-tech stuff right, not because they can do all this high-tech stuff, putting catheters up into your brain and sucking out clots and things like that. They do all the low-tech stuff right that you can do in your small community hospital. They don't put in as many Foleys. They get patients up and walking early. They do the swallowing studies. They do all the low-tech stuff right. So that's the benefits of stroke units. All right, secondary prevention. Patient comes back to your office or you're seeing them in rehab. Now you got the following recommendations. When it comes to hypertension, you get to start or resume the blood pressure medicines. People often ask me in this Q&A, I told you, don't treat the high blood pressure when they hit the door, right? When they have the ischemic stroke. I often get the question, well, when do I start treating their high blood pressure? And the answer's on the slide there. They say, beyond the first several days. That's the answer. Somewhere beyond the first several days. 3, 5, 7, it's up to you. All right? Lipids, control those, especially if they've not been on it. Glucose control, yes, good. All these things are good things. We'll talk about doing the carotid artery evaluation momentarily. All right, let's move into TIA. I want to just move into TIA simply because the rules have changed here a little bit. So, TIA definition. Simple thing. What's a TIA? Is it A, a sudden focal neurologic deficit caused by focal brain ischemia or vascular origin that completely resolves in 24 hours? B, brief episode of dysfunction, less than 1 hour without evidence of acute infarction? C, again, that brief episode of neurologic dysfunction, less than an hour with hyperacute changes on MRI? Or D, a transient episode of neurologic dysfunction caused by ischemia without infarction? Okay, love it. But only 35% had the right answer, which is D. D. Most of you picked the 24-hour thing. Let me go through that and why the 24-hour thing went away. Okay? We all grew up with the 24-hour thing, or at least I did. All right? That went away in 2002. In 2002, there was the TIA working group who said, wait a minute, what's so special about 24 hours? It's so arbitrary. So if you can't speak or talk or move a limb for 23 hours and it resolves, that's a TIA. But if it's 25 hours, that's a stroke. Oh, come on. What's that? I wouldn't want to not be able to, use a limb or speak for 23 hours. Something bad's going on. And so in 2002, they said, we really think it should be about an hour. Okay? That also went away. That's gone also. The whole time thing is gone. Right? And here's the definition. It's a transient episode of neurologic dysfunction. The time thing is gone, and they believe it should be a tissue-based definition. In other words, prove to me it's not stroke. All right. The time thing went away in the era now of MRI. So if you take a patient with this transient neurologic dysfunction and you do an MRI and you do the diffusion-weighted images, which looks for cytotoxic edema, cell death, and as you can see here, even if they've had, in this group of patients, less than 1 hour of symptoms, a third of them actually had cell death. They had a stroke. They actually had a stroke. And the longer the duration of the symptoms, the greater the chance that you actually had a stroke, that you had cell death. You knocked off neurons. On MRI, if you look at these, the diffusion-weighted images, that cell death, that cytotoxic edema shows up as a white, bright white signal like this. That often shows up within minutes of a stroke, okay? There's only a few false negative studies when it comes to MRIs, but for the most part, very, very sensitive for finding cell death. So why is this important? The reason being is that if you've had cell death, if you've had that, all right, you say, why is that important? The person got back to their baseline. They're walking, talking again. What's the big deal? They're back to their baseline. Because those are the ones who had cell death, their prognosis to go on to the big bad one is much worse than those who did not have any cell death. So it's for prognostic purposes, Okay? Now, American Heart, American Stroke want you to sort of use this algorithm. You have that person who had, I couldn't speak, I couldn't move something for a transient period of time. You don't know now, is it TIA or is it a stroke? Is it a TIA or a stroke? They want you to get the MRI. They want you to get the MRI within the first 24 hours of symptoms. If it doesn't light up, that's a TIA. If it lights up, you had a stroke. And in this in-between period where you don't know what it is yet, they want you to call it acute neurovascular syndrome. That's the phraseology they want you to use. So, has the patient had a stroke or a TIA? When it comes to the anterior circulation, one of my neurology colleagues taught me this. I like this. I like to remember it this way. If it's an anterior circulation stroke or TIA, you've lost something. You lost the ability to speak for a period of time. You lost some sensation. You lost some vision. You lost some strength. You lost something. I caution, however, on the right-hand side there, the one loss that's not associated with stroke or TIA is loss of consciousness. Loss of consciousness or syncope is not a TIA. Repeat after me. Loss of consciousness is not a TIA. Loss of consciousness is not a TIA. Thank you. All right. Drives me crazy when I see residents at their discharge. They admitted a patient for syncope. The workup was negative, and they write down TIA as the cause. It's not a TIA. Syncope is global hypoperfusion to the brain. You don't feed blood to your brain. Your brain says, "Oh, I'm shutting down." Boom, down you go. You're flat for a short period of time. You reestablish enough blood flow. Your brain wakes up and says, "I'm back." Right? That's not a TIA. And think about it for a moment. How would a TIA cause you to lose consciousness for a short period of time, 30, 60 seconds, 2 minutes maybe, and then come right back? How would a TIA do that? Well, what keeps you awake? What part of your brain keeps you awake? Your reticular activating system, right? Your reticular activating system is located where? It's that eensy-peensy spot right there, dead center in your midbrain. All right, now think about them for a moment. You're going to throw a little ischemic event to that one spot, right there, dead center in the middle of the midbrain for 1 or 2 minutes, hit nothing else, and then you're just fine afterwards. It doesn't happen. Right? It may happen, and you probably heard a case report, I'll buy that, but it doesn't happen. Syncope is not a TIA. All right? There's a number of stroke mimics also. Syncope is a stroke mimic. There's a lot of other stroke mimics, seizures, with Todd's paralysis. You know them all, complicated migraine, hypoglycemia. There's a lot of mimics. All right, so now you have that person who's got a TIA. You're worried that they may be going on to the big bad one. They have this acute neurovascular syndrome. They might be going on to the big bad one. How can you calculate out their risk of going on to the big bad one? The American Heart, American Stroke Association recommends that you do the ABCD squared score. And what is that? So here it is again. It's a point system. Don't try to remember 1 point for this, 2 points for that, et cetera. But the long and short of it is the more points you have, the greater the risk that you're going to go on to the big bad one. Consequently, American Heart, American Stroke Association said, listen, if you have a high score, 3 or more, you should be hospitalized and urgently, quickly evaluated. Get your workup done somewhat quickly. All right? And I actually like this. So I have patients who come in at 2 in the morning. I can't get an MRI at that point in time. So I have this acute neurovascular syndrome. I call up the admitting doctor and I say, your patient's here with acute neurovascular syndrome. They couldn't, they couldn't speak for 30 or 45 minutes. Now it's back. I'm a little concerned. I'd like to admit them. And they tell me on the phone, oh, you can send that home. I'll see them and follow up. And I say, oh, no, sir. I'm sorry. The ABCD squared score is 5. I need to admit the patient. And usually there's like silence on the other end of the phone. And they're like, what? Oh, okay, admit him to my service. All right, and that's the end of that. So that's how you can use the ABCD squared score. Or if you're on the other end of the line, getting the call from some smart aleck ER doctor, now you know what's coming. Okay? ABCD squared score is useful. All right? Very good. All right. The evaluation after you've done the MRI, let's say it's normal. Now you're going to go searching, was there an occlusion of the carotids? If there is, you'd start with your duplex ultrasounds. You know to start there. And then if the duplex is equivocal, not a good study, you go on to MRI, CTA. If they have disease in the carotids, who goes for endarterectomy? If they are symptomatic patients with 70 to 90%, 99% stenosis, they go for carotid endarterectomy. If they have 50 to 70% stenosis, you get to consider it some more. All right? Word here is symptomatic. If you have asymptomatic patients, first of all, we'll talk about this. Should you do carotid screening? So here's the question in asymptomatic patients. USPSTF has said in adults 65 years of age who should have ultrasound screening for carotid disease. All adults over age 65. That's A. Did they say B, adults 65 years of age with diabetes should have carotid ultrasound screening? C, adults with any of the risk factors should have ultrasound screening? Or D, you shouldn't be screening for carotid artery disease in asymptomatic patients? The answer would be great, excellent. Should not be screened for carotid artery disease with ultrasound. Bottom line, the prevalence of disease is very low in our elderly population, and you'd have to screen tons and tons and tons of patients to prevent one CVA. That's the long and short of it. Meanwhile, you'll get a lot of false positives in the interim, and you'll end up doing a lot more harm than good. Here's your answer key. I'll say thank you very much.